Okay.
Thank you. So, sorry. Apologize because of, yeah, all these issues. So we can start if it's right for you. There is anyone, Runa? Okay. Hi, everyone. Apologize for this delay because of technological issues. Thanks for attending once again to the AFIN seminar. The AFIN seminar of today called Aging and Reproductive Decline in Assisted Reproductive Technologies in India, Mapping the Management of Eggs and Wombs, is presented by Anindita Majumdar. Anindita Majumdar is an assistant professor in sociology at the Indian Institute of Technology, Hyderabad. She has been researching commercial surrogacy, kinship, and infertility since 2010. She is also the author of the book Transnational Commercial Surrogacy and the Unmaking of Kin in India. And she's also an external member of the Center for Reproductive Health at the University of Sussex. So having said this, I would like to remind you that we are starting the live on YouTube, as you could see, and at the end of her presentation, we will have a space for debate. So I will give the word to Anindita. Anindita, whenever you want.
Thank you, Vanessa. Thanks a lot. I want to thank AFIN for extending this wonderful invite. I'm so glad to be here today. How much time do I have, Vanessa? I'm not going to take more than 30 minutes. So I'll just share my screen. Can everyone see the screen? Okay, great. This paper is based on fieldwork I conducted in 2018 and 19. And I primarily, sorry, can you, yeah.
We can't hear very well. I think there is some maybe internet connections.
Can you hear me now? Is it better now?
Yes.
Okay, I just have to move closer to the screen. Can you hear me now?
Thank you.
Yeah? Okay, great. All right. I'm so sorry about this. So the paper is, it looks at two particular cities, and I'll come to that as we go along. But what essentially I'm looking at in this paper is how assisted reproductive technologies actively disaggregate the female reproductive body into different parts and create a non-holistic perception of the female body in infertility management and treatment. What is also interesting here is, and what I found in my research is, the way in which the menstrual cycle is placed within this entire structure. And the menstrual cycle and its imagining and its identification within assisted reproductive technologies treatment is a very important part, but is often not discussed or given as much importance within social commentary, within treatment cycles either, or within even academic conversations around infertility. As I mentioned, the three primary focus areas that I'm looking at, of course, the disaggregation of the female body, the separation of the egg and the womb. I'm also looking at how primarily age comes to be factored in this relationship of eggs and wombs, and how reproductive decline is, within infertility management, there is very little idea of what actually reproductive decline is in relation to aging, but there is a lot of commentary and moralistic positioning around reproductive decline and aging, or women who do not have children beyond a particular age. I also want to kind of link my research to emerging discourse within anthropology on egg freezing, and the kind of research that's being conducted on women who become older mothers post menopause. And I want to position my research right in between to suggest that while in terms of a mainstream ideology, there is a lot of positioning of age and aging linked to reproductive decline. So I'm specifically referring to the work of Lucy Vanderbilt and Lauren Jane Martin, and their discussion of also how particular kinds of how egg freezing sells itself through the construction of this idea that if women postpone pregnancy and childbirth, their eggs are going to deplete and they have to use IVF. I want to actually look at how in India.
Anindita,
Yeah.
Anita, sorry, but I think there is some things with the sound.
Okay,
Some
I think
issues with the sound.
I have a really loud ceiling fan. Is that interrupting? I'll just switch it off. Just give me.
No, I think it's the internet connection.
Oh, really? Okay.
Hmm.
Oh. No. Seems to be okay. Ugh. Okay, I can. Would it help if I switch off my camera?
No worries.
Yeah, I'll just switch off my camera and let's see if that works. Okay, and I will just switch off.
Let's see.
Right. Is it better now?
I think so. Yeah, let's try.
Okay. Okay. So as I was mentioning, I am actually placing my work within a larger academic literature on egg freezing, which suggests that women should have children. Now, is it better, Vanessa, now? Slightly?
Yeah, I think it's better. Yeah.
Okay.
Thank
In
you.
case you can't hear, just let me know. I'll see. I mean, internet here. So there is. So what I am trying to say is that in India, the complexity of age and reproductive decline is put into stark contrast, as I see in my fieldwork, where I see 20 to 30-year-old women going into the IVF clinic, as well as 50 to 60-year-old women going into the IVF clinic for pregnancies. And ideally, within the larger discourse on egg freezing, on IVF, on pushing for fertility treatment, there is this sense that women should have children in their 20s rather than later, or if they want to push motherhood later, they should go in for active egg freezing. I actually want to suggest that in reality, fertility medicine creates a certain idea of aging and reproductive decline, which is very problematic. And Manon Vial actually talks about this, and she actually places the idea on how infertility medicine separates the egg and the womb. So the egg becomes, the fixation on egg is linked to pushing women into having children within 20 to 30. And the womb is something that is characteristically ignored, but comes to become very important for postmenopausal women. So I don't want to confuse people anymore, but I just wanted to talk about my field. So so I did fieldwork in 2 cities in India. One is, of course, where I live and work. Hyderabad is in southern India. And I did my fieldwork in North India in a place called Hisar, which is in the North Indian state of Haryana. In Hisar, I primarily did work in a clinic called Shikhar. It's a pseudonym. Shikhar was very famous and had been covered in the press because the IVF doctor primarily catered to elderly women, women above 50, 60, 70, having babies through IVF. And this was very interesting for me because in the Indian press, the IVF specialist had been actively criticized for putting older women's lives at risk by pushing pregnancy. So one of the cases that he facilitated was in 2018 of this older woman who was 70 years old and who gave birth to a boy after decades of childlessness. So there was this demographic. And then in Hyderabad, I found most of my demographic was of 20 to 30-year-olds. So just to give you a brief idea of my, So if you look at this table, the average age of women in Hisar who were seeking treatment, I interviewed 17 women, and the average age here was 42.23. And amongst the 17 women, and this is, I found out about their fertility ailment mainly from the women because the doctors wouldn't really discuss their medical records with me. So these are in interviews, and they disclose their ailment, their what kind of ailment they were suffering from. So amongst the 17 women interviewed, the highest number of women, around 5, had ectopic pregnancies at some point in their life, could have been in the 20s or in their 30s, that had led to blocked fallopian tubes. 3 did not know the reason for their infertility. Another 3 were trying to get pregnant after having lost their teenage and adult sons to accidents. So this was a very interesting demographic of older women who had children. Many of them had like a son and a daughter, and their son had died due to some disease or a road accident. Usually the son who had died was in his early 20s or was a teenager. And these women would come back to have another child in their early 50s or late 40s, because it's very important within the North Indian setting, especially, to have a son, if not the whole of India. Sons are an important source of not only carrying the generation forward, but also investing in old age care, and also being a heavily patriarchal society, investing in the son and having a son was essential to fulfilling the life cycle requirements, especially amongst Hindu Indians, practicing Hindus. So a lot of women came perforce hoping that they would have a son through IVF. And 4 of the women who in the Hisar, Haryana demographic were trying IVF because of their husband's low sperm count. Their husbands were also older. Interestingly, in the North Indian demographic, many of the men were older and had married twice or thrice, but none of their wives had given birth, which also points towards an interesting aspect of how there might have been a huge fertility problem in the husband, but was not discussed openly. So, and one of the women mentioned that she had a tumor in her uterus or uterine fibroids, while another woman had polycystic ovarian syndrome. Finally, one woman cited age and obesity as issues behind her infertility. On the other hand, in Hyderabad, where the average age of the 29 women interviewed was 30.1 years, and amongst the 29 women, a significant number of women identified their reproductive ailments as cysts, including ovarian cyst, endometrium cyst, hormonal imbalance leading to the formation of cysts. And 7 did not know the exact reason for their infertility, which is also a very big number, or refused to divulge it. 3 had been diagnosed with polycystic ovarian syndrome or diagnosis. And 2 women identified their infertility issues as emerging from irregular periods. 10 women had a variety of infertility issues, including age, husband's low sperm count, and multiple miscarriages or abortions. So there is this interesting age demographic that I found in 2 different cities. Just to tell you a little bit about Hisar. Hisar is in North India, is primarily agrarian. There is most of the economy in this part of the country is run through agriculture. So a lot of the people who came to the clinic for fertility treatment were farmers and were ranged from small farmers who had small land holdings to big farmers with huge acreage of farming land. And in Hyderabad, on the other hand, which is a big metropolis in India, most of the clientele in IVF clinics consisted of women who were professionals, who worked in engineering, in information technology, in software. Most of them were employed, they were working, they were educated, whereas in Hisar, most of the women were school dropouts. They had not completed their school leaving education. Whereas in Hyderabad, the clientele was more cosmopolitan, more educated, more aware of what kind of medical access they could have. And there were more marriages that are now popularly, in academic literature called companionate, where unlike the traditional Indian arranged marriage where families come together to arrange marriages, in case of Hyderabad, many of the couples had chosen their spouses. So they were choice marriages. They had fallen in love and married and had not necessarily had arranged traditional marriages. So within this setting, I find that a lot of women in Hyderabad are in their 20s and early 30s, and they are going to the IVF clinic to conceive. Now, it's interesting why this particular demographic has to go to an IVF clinic. There are a lot of reasons. Some of them I don't discuss in this paper, like many of the women cited, many of them had not conceived, they had not consummated their marriages, they had not had sex. So it could be for a variety of reasons. They didn't know, because India is such a closed traditional society, many young children are not told about sex, they're not trained properly. Training is the wrong word, they're not socialized into it. So sex remains a very taboo. It's a topic which parents don't like to get into. Sex is also seen as dirty. So a lot of young women grow up not knowing about sex and get married and may not be aware of how things work. So many marriages are not consummated. And in my interview profile, there were many who had husbands who were closet gays, who were in the closet, who were homosexual, and who had not discussed it before getting married, which also led to obviously a non-consummation of the marriage. So a lot, and other than that, there were of course issues of actual fertility issues which women were coming up with. But I want to say that the notion of a fertility issue became hugely problematic in the clinic because of certain ideas. So first of all, there was this whole notion of declining egg quality. So most of these women would talk about how they were in their 20s and 30s. They had supposedly they had a whole repository of eggs, but when they would go for treatment, the doctor would say that your egg quality is not good, or either you have a cyst which is affecting your egg quality, or you have other things going on. The doctors wouldn't suggest egg freezing, but most of the diagnosis would be blurred in this whole conversation around eggs and egg quality, which the women wouldn't understand. Often, many of these women would begin their treatment with the most simpler assisted reproductive technology, which is IUI, or intrauterine insemination, where the doctor directly inserts the sperm, the extracted sperm, into the woman's ovaries through her vagina using a long syringe-like instrument. And it's the simplest assisted reproductive technology. It's cheaper. And I found in Hyderabad that a lot of women undertook IUI, but it wouldn't lead to a pregnancy. And then the doctors would immediately transition them into IVF, or in vitro fertilization, which is much more expensive, and which involves the fertilization of the egg and the sperm in the lab under the microscope. It's not micromanipulation, but it's fertilized in a particular in the lab environment. And IVF is definitely more expensive, more cumbersome. Women had to undergo deep hormonal treatments, and they had to go long. They had to undergo huge health issues to be able to give eggs for extraction, which would then be fertilized. But eventually, most of the women we interviewed transitioned from an IUI to an IVF, which involved undergoing multiple cycles, which each of the cycles were very expensive and would mean a drain on family resources. But even then, pregnancy was not exactly always guaranteed, because IVF is not exactly a huge foolproof technology. So there was a lot of problematic diagnosis that was going on. But most importantly, what I found was that there was this notion of the irregular period that became part of most of the diagnosis that was happening. So an important element in the narratives I'm reading here now, in the narratives and identification of the depleting egg, is the role of the menstrual cycle. The menstrual cycle forms a missing element to most analysis regarding the identification of infertility and its management, especially in marking the transition from IUI to IVF. Emilia Sanabria finds that the menstrual cycle is perceived as the death of an egg, or the prospect and certainty of a pregnancy and child. But the irregular period is saw with order and rhythm and signals a pathological uncertainty. Marsha Einhorn finds Egyptian women linking menstrual irregularities to infertility. Inevitably, she says, menstrual problems are viewed in terms of abnormality and irregularity, which can be overcome through regulation. Thus, an abnormal period, an irregular period, or too many periods each month are all deemed to be causes of infertility. The lack of a period is also considered a dire problem. Such an analysis is in contrast to Mizuho's findings amongst Indian women, where the missing menstrual cycle may be seen as the sign of a pregnancy and lead to celebration, especially among skin of infertile women waiting for a child. But the eventual onset of bleeding may be construed as a sign of miscarriage rather than an irregular period. Amongst the 29 women interviewed, the irregular period was often mentioned by women between the ages of 20 to 30 years. But it was the irregular cycle that became the subject of infertility management and ailments. I would like to note here that the irregular cycle repeatedly appeared in the narratives of many of the women interviewed in Hyderabad. For instance, Sujata, 31, has a problem of irregular cycles and is taking medication for it for the past 3 months so that her ovulation can begin. She says, the doctor has suggested that we go for an IUI. We have no time for intercourse. My husband is traveling on most days. Currently, I'm on my 4th cycle of IUI, and this month they asked me to come during my ovulation period for blood test. However, Sujata's natural rhythms are linked to the erratic nature of her sexual relationship. The irregular period becomes a symbol of the interventions in the intimate life of the couple. This is seen in the way in which the doctor's recommendation suggests IUI to facilitate natural conception, especially since regular sexual intercourse due to a husband's absence has been missing. And in various narratives that emerge, there is a sense of disaggregation and multiple diagnosis that doesn't arrive at any kind of certainty about the fertility problem. So as you can see here, Divya, 24, says she's struggling with the cyst that they found. They have given her birth control to control it. And eventually, even before, and she also has an issue of irregular periods because of the cyst, but eventually they suggest transitioning from IUI to IVF because there is no solution emerging to control the cyst and to control her irregular periods. So there is, and similarly again with Swati, who's 26, the whole point being that these are young women who are starting very early in the treatment. They're going to the clinic really early on. They're trying to ensure that they get pregnant as soon as possible. And the question of the quality of eggs is never really under scrutiny. For instance, in case of Swati, the doctors keep telling her that her eggs are, not viable. But eventually, when she's given hormonal injections, they end up extracting 31 eggs. And this is a story across the board. I have, during interviews, I've heard women being told that their eggs are weak, horrible, etc., etc. They go in for hormonal, they go in for their ovum pickup, and doctors extract close to 19, 20 eggs. And then they're told that out of the 20 eggs, only 3 are viable. So there is a lot of there's iffy diagnosis and treatment that's going on in case of how assisted reproductive technologies manage fertility or suggest that they manage fertility. Similarly, Sharanya also has a problem with irregular periods and there's pain, but there is, even before there can be a conversation on sexual health, on reproductive health, there is a lot of pain management and conversation about getting more technology in, right? Okay. 1, 2, right. So, in contrast to Hyderabad, where all these 20, 30-year-old women are going to the clinic and putting themselves through the rigors of technological intervention and not getting proper diagnosis, in Hisar, there are older women who have been through decades of childlessness, have been through different kinds of treatment, and finally are arriving at this clinic to help get pregnant. The interesting thing here is that unlike in case of the 20 to 30-year-olds where the menstrual cycle is irregular and has to be managed, here the menstrual cycle is resurrected. These are women whose menstrual cycle has stopped. They do not produce any more eggs, and the reproductive journey is now coming to an end. But interestingly, the uterus is still viable. So there is a plotted resurrection of the menstrual cycle. And so the doctor at Shikhar Clinic that I was interviewing and I did field work at for almost 6 months, suggested that this is, they restart the period through hormonal drugs, and then go on to facilitate, then prepare the womb for transference of the embryo. But there was a lot of conversation that tried to block out the conversation on where the egg is coming from. So a lot of the women who were from rural parts of India, as I mentioned earlier, formal education was not part of their upbringing, so many of them were school dropouts, presumed or tried to hide the fact that they had used egg donors. There was a lot of, I was never told directly that there was an egg donor involved. None of the women I interviewed would suggest it. Many of them who were above 50, whose menstrual cycles had stopped, would suggest that the doctor had given them medicines which had led to the menstrual cycle restarting again. And somehow that was meant to suggest that they had become fertile again, that they had started producing eggs again. Though I refuse to believe that these women thought that they had, after menopause, that they had started producing eggs again. But there was this certainty around their reproductive health, which is very interesting. So a lot of this conversation in Haryana is also linked to the idea of the womb. So, for instance, in India and in South Asian cultures, procreation ideologies give a lot of value to the womb. So the procreation ideology regarding seed and earth, where the earth is supposed to signify the womb, suggests that pregnancy is the most important aspect of a woman's life cycle. Motherhood and pregnancy give her value. So visible pregnancy is more important than going into conversations about whose egg is involved in facilitating conception and pregnancy. And as long as the older woman had a swollen stomach, could show her pregnancy to her neighbors, to the world, to people who had earlier thought she was infertile and childless, it was a big deal. And there was a lot of secrecy around using egg donation, etc., and who the egg donors were. So it was easily constructed as her pregnancy. So, for instance, Dr. Anuj says the visible pregnancy was deeply valued, and as Dr. Anuj mentioned, motherhood is through the act of pregnancy. He says here most people believe that the woman who carries the child is the mother, which is why Dr. Anuj proudly advertised the pregnancies that he had facilitated amongst 3 of his patients, aged 66, 70, and 60. All 3 had pregnancies and delivered their children through cesarean, and all 3 had suffered decades of childlessness. Here, the pregnancy was a symbol of the reframing of age-related reproductive decline. This was similar to Chiaki Shirai's study of Japanese women navigating third-party participation through an egg donor who valued the pregnancy over their genetic connection with the fetus. In India, the folk procreative ideology regarding seed and earth identifies the uterus womb as the prime repository of the man's seed. Agrarian symbolism is very particular for rural Indian patients frequenting Shikhar Clinic, and the uterus comes to occupy center stage within such a discourse. However, and this is important, surrogacy was not a popular option amongst the women frequenting Shikhar. Gestational surrogacy depends on third-party participation of another woman to carry the artificially fertilized embryo, effectively negating the value of the visible pregnancy to offset decades of childlessness. Even though for many of the women at Shikhar in their late 40s and early 50s or in their 60s, the visible pregnancy is a huge attraction, it is important to note that the uterus womb was also under scrutiny for signs of aging. 2 out of the 17 women interviewed in Hisar had uterine fibroids, which they referred to as a knot in the womb. The uterine tumor of fibroids is a common ailment amongst the women visiting Shikhar Clinic. The issue of uterine fibroids stemmed from a variety of past reproductive ailments, such as ectopic pregnancies leading to lost fallopian tubes or blocked fallopian tubes. Many of the women interviewed in Hisar mentioned having their tubes blocked, which was not diagnosed in time. In Hisar, 5 of the 17 women had ectopic pregnancies who had ectopic pregnancies were diagnosed with tubal blockage. In Hyderabad, on the other hand, 6 out of the 29 women had between 1 to 2 miscarriages and abortions, though the exact reasons were not cited. Except for 3 women, none of the others mentioned any diagnostic problems with the tubes or uterus. Angrezo, one of my respondents, who was 52, was diagnosed with uterine fibroids at a small clinic in her village during one of her many treatment cycles to get pregnant. The clinic told her that she would have to remove her uterus to remove the fibroids. She says, "For me, it was like the end, no hope of any children." But then she came to Shikhar after reading about the clinic and its list of older pregnant women in a local newspaper. She was able to get pregnant through IVF after her fibroids, which was a benign tumor, was removed by Dr. Anuj. So a lot of the conversation around older women is to protect, first of all, the secrecy of using egg donation from younger women. And secondly, to heighten the fact that they have their own physical, visible pregnancies, because that is what is valued in that particular cultural setting. In this case, their past reproductive history becomes very important to actually gather whether they can even carry a uterine pregnancy, carry a pregnancy to term. Many of the women did it, but most of the deliveries were cesarean and not normal. So this is, of course, these are the quotes. Dr. Anuj in particular says that aging means weakness and debilitation, especially when the endometrium tissue begins to degenerate. It's interesting how he tries to position degeneration in a very mixed sense. So while he talks about how the uterus might degenerate, in the same breath, he talks about how older women face similar morbidity as middle-aged women. This is part of a larger conversation where he's trying to champion the fact that older women can also get pregnant. He actually positions himself as a feminist, which is, to me, it was hilarious. But he tries to position himself as a feminist who's a champion of women who have been childless all along, whose husbands have married twice or thrice, and he now wants to make sure that they eventually give birth to their husband's children. So a lot of the conversation in North India and the clinic I worked was about birthing their husband's children, about having heirs, having descendants to inherit land, to inherit property. And so it was important to have a son as well in this conversation. So in conclusion, I want to say decades of misdiagnosis are blended into the narratives of childlessness that women in rural India encounter. These may not be effectively treated while doctors embark on new forms of intrusive treatments and effectively put the lives of elderly women at risk during pregnancies and cesarean sections. The issue of comorbidities and health risks to the elderly woman and the fetus infant was an important part of the discussion circulating in mass media reportage regarding Shikhar Clinic. Dr. Anuj was referred to as the rogue doctor for purposely endangering the lives of these women, which he countered with his specific answers regarding medically sustainable pregnancies amongst elderly women, and also by positioning himself as a feminist, providing women relief from decades of social stigma due to childlessness. His patients were happy because they were finally able to have children, and those who had miscarriages after their IVF cycle would come back for repeated IVF cycles till they got pregnant. In such a situation, elderly older women didn't care if they died while giving birth. For them, it was important to fulfill their elusive destiny of motherhood. Thank you.
Thank you so much, Anindita. And apologize once again for our technological issues.
Yeah, I know. I'm sorry too. I hope everybody was.
No, sorry for us. Sorry for us because there some issues. So we have I think Anna wanted to say something. Or
Well, I didn't raise my hand, but I will take the chance to say thank you so much for the.
I thought your hand.
No, but it's all right.
Okay.
It's all right. I'm happy to to start. Thank you so much for the presentation. I really enjoyed, and I think well, this is another issue. But I saw that you will be in Finland. Is that right? Presenting that same paper.
Yes, but not in person, unfortunately. Again,
Oh,
online.
okay.
Yeah, I'm unable to travel, but yeah, I would have loved to be there. Yes. Will you also be there?
I will be there. Yeah. And I was thinking that maybe we would meet there in person, but yeah. Anyway, well, hopefully we'll have another chance.
Yes, I feel really bad not going because there's so many people there who will be, at Finland in attendance. But yeah, I mean, hopefully someday this part of the world, maybe in India, if you all of you are coming this side, it would be lovely to host all of you.
Yeah, that would be lovely. I don't know. So many aspects of your research. I don't know. I thought it were super interesting. I don't know. I guess I was thinking about the issue that I've done more research about, that is egg donation, no? And this issue that they actually use egg donation, no? I guess that most of them must use egg donation, especially when they are over 40 and so on. And yeah, I don't know. I was wondering about this taboo in society, if it's something that somehow people knows but they don't talk about, or people actually don't imagine that these women are using an egg donor. And also, I don't know if you know these egg donors, where they come from, if they are also from the same regions that, if they live around the clinic, if they come from other places in India, if there is like a circulation of women in this sense as well, and yeah, how this all is organized.
So egg donation is also part of the surrogacy industry in India. Many of the surrogates in India, now of course commercial surrogacy is banned, but egg donation is not banned. So many of the women who would become surrogates, the first thing they did was they started with egg donation. They would be, the doctors, many of these women would be first introduced to egg donation, and then they would transition into surrogacy. So it was an interesting path. The egg donors I have interviewed as part of my research on surrogacy earlier, again, they're from very lower socioeconomic background. They're mostly selling their eggs. But there's a flip side. There's another group of women who are college educated, who are very upwardly mobile, who would also give their eggs to earn some extra cash. And so because I don't know how to do the conversion. Yeah, that will take a lot of time. But the kind of money the women, so there would be a list, right? So, and I think Renee Almeling has talked about this in her work. In India too, the list so the university educated, fair, middle class women would be on the top of the list as egg donors. They would be category A. And the school dropouts, the socioeconomically poor women would be category D or C or D, the lower categories. And then when I was doing my fieldwork in 2010 to 13 on surrogacy, India was thriving. There was a huge transnational industry, and most couples who would come in from abroad would be shown this list. And there would be, if they didn't have anyone they wanted. So a lot of the couples, including a lot of the gay couples who came from Australia, who were part of my, respondents, they would actually ask for, many of them would get white egg donors from Ukraine, from, the Eastern Bloc. But that would be very expensive because you would have to fly the women down to India. They would have to give their eggs and then fly back. So it was expensive. Many of them couldn't afford because they were already spending so much money, even though it was cheaper than going to the US and elsewhere. They would prefer to go in for an Indian woman who was a school dropout, the lower category. And many of them, it was interesting because I interviewed so many of these fathers, and they would say that, what difference does it make whether I choose a lower category egg donor or an upper category? Because maybe if the lower category egg donor had the opportunity to study, she could have gone on to university. So it was an interesting kind of reasoning. A lot of the fathers, even heterosexual couples who had babies, would use. So it was expensive, but the egg donation industry in India is huge. It's thriving. There is research about it, but not too much. And mostly women. In answer to your question about whether the people in rural Hisar knew about, it's a very good question, because many of them didn't, because in rural traditional sense, the pregnancies are unified. It's only with the coming in of IVF and with assisted reproduction that there's been a disaggregation, that we know eggs can be extracted and uteruses, and you can, but otherwise the idea of the pregnancy is a unified body where the egg and the uterus, where the ovaries and the uterus combine. So many of them actually didn't know about this disaggregation, and they didn't want to know. How did it matter? The visible pregnancy was definitely more important. So many of the women thought it was miraculous that they were suddenly bleeding after hitting menopause. Like many of them one of these women told me, she said, no, I don't know how it happened, but I suddenly started bleeding. The doctor gave me a medicine and I was bleeding and I got pregnant. So it was, it also follows with the fact that the medical professional in India is seen as God. In India, the doctor is close to a deity, because they save lives. The IVF specialist is a bigger God because he or she is literally giving birth to a child, So the religiosity linked to the doctor is very important and so if the doctor made them bleed, he's God, he can do it. That's part of the understanding in the discourse. But thanks for that.
Thank you. Super, super interesting.
Thank you.
I got a question, if there is no other question. Yeah, I was wondering about, because I've seen that the menstrual cycle, so there is a discourse around the menstrual cycle, and I was wondering how the women's, so how, if in your sample, if the women's talk about the relationship with the menstrual cycle of
So many of them, so there is this perception that if you have irregular cycles, so as I mentioned, in India, if you miss a cycle, if you miss a period, then you're pregnant, and there's a huge amount of, so it can differ. If you're an unmarried single woman and if you miss a cycle, there is complete chaos, because and if there's fear about pregnancy, and this, a lot of women, I myself went through this. I think I was 16, and for almost 6 months I didn't have any of my periods, and I could feel palpable anxiety at home, even though I never had sex. I didn't have sex with that, but there was anxiety about what this meant. Was I pregnant? So I had to actually tell my mother that I've not had sex, and this is something else is going on with my system. But this anxiety is linked to before marriage and after marriage. If you miss a cycle, it's a huge deal. That means you're pregnant, which is of course the destination for all married couples in India, to be pregnant eventually and to bring together their conjugality. But so there is if the missing period does not lead to a pregnancy and it continues, if it becomes a cycle, then post-marriage, women have to be sent to the clinic. It's understood, because if you're not getting pregnant and you're not bleeding, then there is a huge problem. So, and this is something that a recent paper actually, it was published in a special issue in the Asian Journal of Women's Studies. It says how a woman who's not having her cycles pre-marriage may not be suitable for marriage. So word gets around that this young woman either has irregular cycles, one doesn't know for what reasons, it may be polycystic ovarian syndrome. So the word gets around, and she may not be eligible for marriage. Many people may not want to marry her knowing she has fertility issues. So periods figure in a very big way in how women in India think of their fertility health. The thing is, I think they go to the clinic and they discuss their periods, and the doctor is very much part of that discussion. But then at some point, there is some level of misdiagnosis. So a lot of it is linked to cysts. I think Gauri Pathak, who's at Aarhus, has written about the polycystic ovarian syndrome. Her work has been on PCOD. And in India, currently, in middle class India, a lot of women suffer from PCOD. A variety of factors: overweight, sedentary lifestyle, genetic issues. And PCOD has become a fertility health problem in middle class India. And a lot of 20-year-old women, before they get married, actually get themselves treated because it's going to impede their pregnancy chances. So the irregular period, not the irregular single period, but the irregular cycle has become a problem in that sense. It has become, it has to be treated because it does not bode well. And most women know that they can make that connection.
So, for example, if there is an irregular period, they will relate it straight away to infertility instead of trying to find to seek for other issues related with menstrual cycle.
No. I mean, I think there are stages to this. So if you're unmarried and you figure out that you're having a cycle, like you haven't had your periods for more than 6 months or a year, most women would go to the obstetrician gynecologist, and then they would be routed through doctors, etc. The most common form of medication that young women who have irregular cycles, you're given a birth control pill to get it back on track. However, some get diagnosed with PCOD. If you're married and you are having irregular cycles, it's been more than 6 months or a year and you're not having a menstrual cycle, your in-laws will push you into the fertility clinic. They'll not even send you to the obstetrician gynecologist. Because the in-laws in India, because arranged marriages have, your entire, your husband's family is very interested in your reproductive health. And many of them desperately push these women into infertility clinics. So a lot of these 20, 30-year-olds are not coming of their own choice. They are pushed by their family. They said, you have to go. They're told you have to go because, you need to get pregnant and you're getting older and then you won't get pregnant. And there's so much anxiety in the household. And I mean, one of the things that I found very interesting was that we talked to this psychologist counselor at an infertility clinic. And she said, a lot of, as I said, I think marriage has a huge role to play here. A lot of the couples who had choice marriages, like who loved each other and didn't follow the traditional format. So before marriage, many of them might not have gotten sexually intimate because India is a supremely repressed society. That doesn't mean people are not having sex before marriage. There are lots of people having sex, but just the discourse around sexual practice before marriage is very, it's very stigmatized. So a lot of couples don't have sex before marriage. They protect each other. They protect each other's intimacy. And after they get married, they still cannot have sex. And at that time, because their love and their emotional bond is so huge, the partners protect each other and their desire for intimacy. So conception doesn't happen. They're unable to consummate. So the counsel at this infertility clinic was saying that it's a lot of men, for instance, and I find that nice to hear about Indian men, that a lot of Indian men wait for their wives to feel comfortable about sex, about wanting to be intimate. And then, it gets difficult. It just takes on a lot of time. But the in-laws get desperate and push the woman to the fertility clinic. So, marriage. So it's not always, the first stop is not the fertility clinic. The first stop is the OB-GYN. Yeah. And then there are other local medicines also that women take. A lot of, we have homeopathy, a lot of different kind of folk medicines that women take, folk treatments to start their menstrual cycle as well.
Okay. Thank you so much.
Thank you a lot.
Vanessa, I don't know if you're seeing, I think Diana has one question. There is some people that is watching the talk on YouTube. and they put a question on the chat, and we're trying
Where?
to figure out.
YouTube?
Yeah, apparently yes, but
no, I've seen. I mean, I can't see on the chat on YouTube. There is nothing.
Okay. Yeah.
Yeah, Bruna said something, but I can't see anything.
Yeah. Wait,
else?
she just said it on WhatsApp. I'm trying to understand, and then I can translate. Just give me 1 minute. Okay. Bruna, you are here. Okay, I was going to translate Diana's comment.
Go on. I was trying to do the same, but I was I was doing the same as you. So go on.
Okay, so yeah, Diana Marre, that I guess you know, she's the director of the group. She just wanted to say thank you for presenting, and she was watching you, but she couldn't. Well, she was watching you on YouTube. And she wanted to tell you that she's gonna get in touch with you soon, because along with another colleague that is called Alex, they are planning. They are working on women who travel, French women who travel to Barcelona to access assisted reproductive treatments, and that they were very stimulated by one of your papers, so that they will get in touch with you.
Thank you, Diana. Thanks a lot. Thank you. Thanks a lot. I think, Bruna, you had a question, did you?
No, I was just thinking that really thank you for this presentation. Okay. And yeah, I was thinking about this menstrual cycle and this relation with infertility that Vanessa has asked. And I was just thinking about how menstruation is only related to reproduction, because it's like when something fails in reproduction is when they look at menstruation, but what happens meanwhile, and perhaps painful menstruation and whatever. And this is very common. I was thinking in different cultural contexts, so I think like it's very interesting point, and I never seen it so related than in your presentation, and I was thinking about that. So really, thank you very much, because it's like this narrative of continuity has been very, very interesting.
Thank you. Thanks a lot. I mean, I think we, you know, when we look at IVF, we look at other things, and eventually one goes back to the base, which is menstruation, menopause. We all go back to the base, you know, and I mean, there's so much about reproductive biographies that doctors don't think about, that we have to think about as anthropologists when we write, how women feel their bodies, right? And there's so much pain. I mean, menstrual cycles are painful for a lot of women in the world. But yeah, I mean, how it can be linked to fertility is something I think individual women can talk about it in their biographies, and that comes out a lot. Yeah. But I was going to say that I'm recently reviewing a book by Marsha Einhorn called Waithood. And Beatrice has a paper in the book on exactly the conversations of, you know, older women getting pregnant and egg freezing. So it's interesting that how everybody at AFIN is also working on interesting themes linked to what we're researching on.
Thank you very much.
No, thanks a lot. Thanks a lot. Thank you for inviting me. Thanks a lot.
Thank you, Anindita. Such interesting presentation. And yeah, once again, sorry for our technological issues. Yeah, we really enjoyed. Is all the presentation is on YouTube, so it's ready for everyone who wants to to see your presentation. If you if it's for you, okay, we can finish the session.
Absolutely, absolutely.
And thanks everyone who attends also to the seminar.
I look forward to staying in touch. I'm sorry I'm not meeting a lot of people in Finland, but thank you for coming.
No, it's been so interesting. Yeah, and there are many questions also, you know, because
Please
And
email.
it's like Bruna said, I've never seen it like the irregularities with menstrual cycles so related with with all reproductive issues. Yeah.
Thank you. Thanks a lot.
So thank you.
Please do get in touch. If you come to India, please say hi. Let me know.
Great.
Thank you. Okay,
Thank you, everyone.
Thank you very much.
Thanks, Anna. Thank
Bye.
you.
Bye.
Bye.